Hi, everyone. Good morning and good afternoon for those participating from overseas, and maybe even good evening. Some of you are up quite late. Welcome to day 2, our second and final day of the Global Health Landscape Symposium. We're excited to be here with you again today and looking forward to a great discussion. Today, we're going to focus in on the relationship between health equity and global health security. But before we move into our official program with our keynote from Dr. Githinji Gitahi of AMREF, I thought maybe we could do a little reflecting on some of the things that came out of yesterday. And I'd love to have all of you share your own reflections. If you could put them in the comment box, we'd love to hear what resonated most with you from yesterday and anything you're hoping to learn today. If you have something you'd like to share, please put it in the chat. And I'll just say, from my view, there was really a lot of interesting discussion yesterday and many, many insightful ideas. So it's not that easy really to narrow down what resonated most for me to any singular idea. But what I keep coming back to is this thread we heard about this balance between health equity and global health security. And it was something I first heard in Dr. Tedros's opening keynote, and then I heard it again in different ways across panels throughout yesterday. And what Dr. Tedros said that has kind of stuck with me and I've been thinking a lot about, and trust me, I'm paraphrasing here, but he said that health as a fundamental human right is an end in itself rather than how it is often considered, which is as a step on the road to some other development, security, or economic goal. And he said that investing in health for health's sake is the smartest thing any nation can do. As an advocate, I feel like I say that a lot, and it sounds kind of like a simple idea, but if you really think about it, I was reflecting on well, is that actually a paradigm shift of how we talk about global health security and health equity? And it made me think about how we framed today's program, which we said is examining health equity within the context of global health security, rather than the other way around. And as I was thinking about Dr. Tedros's words and many comments I heard yesterday across panels about investing in people, meaningfully engaging and sharing power with local communities, and strengthening existing health systems, I was wondering if we would have been more forward-thinking to frame this day in the opposite way, that instead of contextualizing health equity within global health security, we would in fact be making more strides by placing global health security within the context of health equity. And I've been thinking about this a lot, obviously, in reflecting of whether, as a global health community, and this includes governments and policymakers when I say global health community, if we had health itself as the goal and health security as a step on the road to achieving that, would we be in a different place than we are now? And I think that, for me, is the ultimate question I hope we explore today. I don't have an answer, frankly. I don't know if that sentiment from Dr. Tedros is really a paradigm shift, or if it is a game of semantics, or are these two concepts, health security and health equity, inextricably entwined, and we simply can't achieve one without simultaneously achieving the other. Again, I'm unsure of this answer, but I'm excited for the lineup we have today and the potential to further explore this. And luckily, we have a program full of experts who can help us get to the bottom of this relationship. Before we bring on our keynote speaker, well, I was going to lift up some comments, but I don't see any. So please feel free to share reflections in the comment box, and we can come back to those. But let me now bring on our keynote speaker, Dr. Githinji Gitahi. Dr. Gitahi is the Group CEO of AMREF Health Africa, the largest health development international NGO in Africa, delivering health access to more than 11 million people in over 35 countries. Dr. Githinji is a renowned leader on the global and regional front, with notable achievements, including co-chairing the global UHC 2030 movement, serving on the newly constituted Commission on African COVID-19 Response, and serving as a member of the governing board of Africa CDC, among many others. He is a vocal advocate for pro-poor universal health coverage and leads the largest thought leadership convening on the African health agenda. Because of Dr. Githinji's very busy schedule, he wasn't able to join us live, but instead provided a pre-recorded keynote. So let's hear what he has to say. Can we bring up that video, please?
Gitahi, I'm the Group CEO for Amref Health Africa, and also a governing board member of Africa Centers for Disease Control and Prevention. And I'm really honored to be invited to the Global Health Landscape Symposium of the Global Health Council to share my thoughts, though virtually. I would have loved to be there in person, but the current times call for different thinking. And that's why the technology has evolved to allow us to share things virtually, because that's what this current times ask for. So I want to talk very quickly on health equity and health security. As you know, I have a very strong belief that universal health coverage is the best guarantee to equitable health access, and health being a human right, and in my view, the most fundamental of all. It is important that equity in health is actually put at the center of our conversations, including the health security, as has been taught to us by COVID-19. Now, what I want to do is just share with you a few slides, and one of them is to just tell you that the world was and is not prepared. In 2019, this report, the Global Health Security Index report, that's pre-pandemic, showed that out of the various measures of creating global health security based on a world that's able to prevent, detect, and respond to disease, the health system, compliance with international norms, as the International Health Regulations of 2015, and also ensuring that we have a risk-free environment are critical to achieving prevention, detection, and response. But if you look at this chart, it will tell you that in 2019, the health system had the lowest score in the Global Health Security Index. The score was 26.4 out of 100 possible marks. And this made it the lowest scoring category. Yet we know that health system equity will guarantee global health security. As has been said severally, global health security or health security and universal health coverage are two sides of the same coin. If you look at this particular chart, and this is data from that I've obtained from one of the journals, which is reflected there, it shows that in this report of 2019, Africa had the lowest score, whereas the global average was 26%, as I said earlier. You can see Africa was way below average. Actually, the only continent that had a favorable score on health is Europe. And we know that Europe is probably the community or the continent that has some of the best indicators on health equity in terms of access to health services, of optimal quality, and also ensuring there's financial protection. The UK has probably one of the longest histories, Germany, of financial protection for health. And therefore, you can say that there is health services equity in those regions. Of course, we have major challenges in Americas, and we are aware of that because of very market-based approaches. But if you look at Africa, we are at 15%. And I would like to say that if you were to look at disaggregated data for sub-Saharan Africa, it will be lower than 15%. And that also means that unless we can build the health system in our continents to be equitable, then we cannot guarantee global health security for anybody. And I'll show you a very quick chart on vaccination in one of the countries. So just keep that in mind, that health system equity, not within a country, but across countries, across the world, is critical to global health security. But how do you build health system equity? Now, in this chart, it's very clear that a higher universal health coverage index reflected on the lower axis predicts a higher global health security index, which is on the vertical axis. So that means that when you have UHC, by UHC here we mean that you have adequate access to essential needed health services, especially primary health care, that have optimal quality that is able to guarantee the expected results and that are available equitably, meaning without financial difficulty, then you have your universal health coverage. And if you have that mix of those dimensions, then this chart is telling us that you actually have a higher index of global health security, meaning that the foundation for global health security is a strong, equitable health system. Now, this chart also shows that the risks of global health threats like COVID-19 and the capacity to respond are interrelated. So if you see the capacity for GHS, which is captured in what we call the core capacities for the international health regulation, that those core capacities to actually detect and respond are based on the availability of health workers, starting from community health workers, the systems for disease surveillance. It is based on the availability of response teams, epidemiologists, laboratory system strengthening, and also the ability of the health system to take care of those who are unwell in an equitable manner that allows anybody to seek care irrespective of their illness, because they know they are not going to be stigmatized by cost. At the beginning of COVID, we saw in many countries, people actually complaining of huge bills because they were isolated, or they were mandatorily quarantined, but they did not have money to pay for it. And yet this quarantine was a public health good for global health security or national health security, but individuals were made to pay for it. But when you have universal health coverage and therefore improve your capacity for global health security, including protection against financial difficulty, then you see that individuals will come out, that individuals will be able to identify themselves, and you'll have enough time to then respond to the threat if the threat is identified. But we cannot have a situation where people are afraid to come forward, therefore they treat their disease at home, and therefore the risk of spread is higher. And because of the world being a global village and having 25 million passengers, traveling on a daily basis, a village that doesn't have equitable health services does not have a village health security, and therefore that country does not have national health security, and the world does not have global health security. And this is why we must work together, including avoiding to stigmatize countries that have actually reported health threats, like we saw recently with South Africa on the Omicron variant. So this is a case for Kenya. And I think one of the issues that I want to highlight here is that vaccines and vaccine security and access are part of global health security. If you look at, for example, measles, the reason the world has managed to keep measles down and at bay is because we managed to achieve a high level of vaccination. Of course, we still have gaps in the zero-dose children. The other reason, if you look at polio, for example, the world has been able to bring polio to a halt is because of vaccination. So vaccinations are part of global health security to keep disease at bay by creating herd immunity, ensuring you have a hostile environment in the host. Therefore, the virus does not survive, continue to propagate and mutate, and that is critical. Now, vaccines are one way to demonstrate the absence of health equity. We know that right now the world is grappling with significant vaccine injustice. We have called this out in the AMREF Health Africa End Vaccine Injustice petition, which is running currently, which is aimed to ensure that there is vaccine equity across the world, because until everyone is safe, nobody is safe. This inequity between countries is also reflected in inequities within countries. And if you look at that inequity, it is not purely an issue of hesitancy. It is an issue of inequity, health system inequity. Countries that have better funded health systems, where access to services is universal with financial protection, are likely to have a much better access to vaccines than those that are in the contrary. Within countries, as demonstrated by this chart in Kenya, Counties, Kenya has 47 counties. Counties that have better access to health services, in this case, reflected by proportion of population living with less than an hour to an immunizing health facility, you will see that counties that have longer travel time to the next vaccinating facility, which are reflected to my far right, that would be Isiolo, Marsabit, Turkana, Garissa, Wajir, have a much lower vaccine coverage than counties that have a much lower mean travel time to the nearest vaccinating facility. And that would be Nairobi, Kiambu, Kirinyaga, reflected on this other side, on my left side. So COVID vaccines uptake is actually directly proportional to average distance from health facility. You can see that, with a few exceptions of a few counties, like 4 that I've noted there. And these are largely urbanized counties, where therefore there is a bit of a concentration, and therefore they have a much higher uptake. But if you are to remove those, it is very clear that actually there is an inverse relationship between the distance to the nearest facility and vaccine uptake, which says that actually the low uptake of vaccines in low-income countries has absolutely nothing to do with the demand. It has everything to do with supply and access, not demand. And if we can close the access gap by ensuring there is equity in the health system, then we close the vaccination gap, not only nationally, but globally. So equity is at the center of health security. Therefore, as I conclude, I would like to say that what we would like to see is equity in the health system that's driving universal health coverage, driven by or supported by quality, which is good enough to improve health, and also with mechanisms that remove financial risk for households, so that the cost of using the services does not put people at risk of financial harm. So I want to reemphasize, therefore, that whether it is government money, especially protecting individuals, and that's what we want actually that there is government money that is what is used to close the equity gap. We want equity, which is actually what's in the middle, where those who have are given less than those who don't. And that is the basis of universal health coverage. I wish you all the best at this meeting, and I hope that you will agree with me that without health equity, there will be no global health security. Thank you very much, and all the best. And please stay safe. Thank you.
Thank you, Dr. Gitahi. We miss not having you here, but we're thankful that you were able to provide us with this keynote and all the work that you're doing to improve vaccine and health equity in sub-Saharan Africa. I think it was great to see all of the data. We haven't really seen that level of detail before in this conversation, or at least some of us haven't. And it makes you wonder, if we have all of this data and this evidence that what we're doing is not the right thing, how can we turn the corner and really put that evidence to work? So hopefully we'll get to some of that today as well. Before we move to our opening plenary, which is health equity in the context of human-centered global health security policies, we have a short video to share with you. In the lead up to this symposium, particularly thinking of today's program, we asked colleagues from around the world to answer the question, what does health equity mean to you? So we can bring up that video, I think, and hear what they have to say.
Understanding of health equity is ensuring everyone is able to live a healthy life regardless of their background. That is ensuring equal access to health care.
Equity means leveling grants for everyone, including the last mile woman, child and adolescent to access healthcare they need to survive and thrive.
Health equity means providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, social economic status, and geographic location.
Health equity is about being accessible, affordable, and inclusive.
To have access to the opportunities for prevention, diagnosis, and treatment that each person needs to preserve their health and have quality of life without their personal characteristic and social conditions preventing it. That is health equity.
Health equity means everyone has a fair and just opportunity to be healthy.
Equity means our income, identity, race, geography, and legal status do not determine our potential to lead healthy, dignified lives. Our governments put health before profit, and we are actively engaged in decisions that impact our well-being.
Health equity for me means fairness and justice in access to quality health services for all people.
It means reducing and ultimately eliminating disparities in health and determinants that affect excluded groups.
Health equity means everyone can access and afford life-saving medicines like insulin.
It means giving patients the care that they need when they need it, regardless of their personal character, such as gender.
Equity is access to health services based on need and not on payment. In times of pandemic, equity means equal and universal access to vaccination for everyone.
Equity to me means the high physical, psychological, and mental well-being of an individual, which gives them an opportunity to do anything they want.
The mental health is key to knowledge. Mental health is key to every and everybody should have access.
Health equity is the accessibility of healthcare when needed, regardless of gender, sexuality, age, economic status of an individual. And it has to be individualized to meet the person's need.
Health equity means universal health coverage for one and all, especially for people living with chronic conditions and NCDs like diabetes, cancer, etc.
Equity is whereby you ensure that everyone has a chance to be healthy.
Thanks so much to everyone that contributed to that, and to GHC staff member Eliana Monteforte for putting the call out for people to send in videos and for putting everything together. There's a lot of stuff in there. I think we've heard it throughout about really reaching marginalized populations, universal health coverage as being key to health equity, and making sure that everyone has access to healthcare, and I would say quality healthcare. I'm going to bring up our panel in just a second, but I want to just say a couple of housekeeping things. I said these yesterday, so I apologize if you heard them yesterday from me, but I think it's important to repeat. Just a reminder that in the plenary and in the concurrent sessions, you need to use the comment box to put your Q&A. One of our team is monitoring that, so we'll raise the questions placed in there for the moderator during the sessions. The other thing is that we have closed captioning available in all the sessions, and that is in the same area as the comments. You just click on the caption tab if you need to see those. I'd also like to encourage everyone to go to the networking session today. I think I mentioned yesterday how fun that was. And it's nice to have that spontaneity of kind of bumping into people and having light conversations, which is something I think we all miss being in the virtual world. And so with that, I will stop talking and turn it over to our plenary session. And I ask our moderator, Lisa Hilme, CEO of the core group. Hi, Lisa.
Hello, Alicia. How are you?
Good. How are you? Thank you for being here and for moderating this important panel about global health equity in the context of human-centered global health security policy. I am going to exit the stage and let our panelists come up and leave it to you.
Absolutely. Thank you, Alicia. Good morning, everyone. Good afternoon. Good evening, wherever in the world you may be.
Good afternoon.
It's great to have our panelists here as well as all of you virtually. Thank you for joining us today for our discussion on health equity and its critical role in global health security. And thank you to the Global Health Council for providing this forum during the 2021 Global Health Landscape Symposium. Remember to share your thoughts on social media during this session. It's hashtag GHLS 2021 at globalhealth.org and hashtag global health security. My name is Lisa Hilme, Executive Director of Core Group, and I'm a proud nurse and very excited to moderate this very important discussion today. We heard a bit from Githinji in the keynote about equity, and we're going to unpack it a little bit more in the context of global health security. It's really exciting here to see Global Health Council under Alicia's leadership and her fantastic team bring us another annual GHLS. I look forward to this every year, and it makes us think about policy, about advocacy, and more. And it brings together all of you from around the world. Today, you'll hear from 4 exciting panelists with deep expertise at the country level. Jennifer Ho from Apaxo, Dimiso Gitahi from Success Capital, Dr. Mohammed Al-Noor from MFNET, and Smita Sadasivan from the Civil Society Engagement Mechanism of UHC 2030. I'll tell you more about them later. The purpose of this plenary will be to discuss equity, what it means, and how to incorporate and achieve health equity in the context of global health security. Likely, many of you have heard the expression, no one is safe until everyone is safe, during the COVID-19 pandemic. The connection between health equity and global health security has never been as clear as now. We think of global health security as activities required, both proactive and reactive, to minimize the danger and impact of acute public health events that endanger people's lives across regions, across boundaries and borders. We're in the midst of the COVID-19 pandemic, but we want to think about preventing future events and ensuring equity and in learning from this experience. For those listening today, we know that during the COVID-19 pandemic, there have been marked disparities in access to COVID-19 vaccines worldwide, and that the longer people go unvaccinated, the longer the pandemic will continue to ravage our communities, and more variants will rise. What is the intersection of global health security and equity? Well, we're going to unpack that today. We know that according to the World Health Organization, more than half of the people in high-income countries, they've received at least 1 shot of COVID-19 vaccine, some of them up to 3, including a booster, while only 3 to 5% of people in low-income countries and middle countries around the world have received at least 1 shot. This reflects historical disparities in access to essential healthcare services. And we are grateful to all of the partners at the country level and global levels for their hard work in trying to end these disparities. You're going to hear from 4 of them today. And there are others, community health workers, nurses, doctors, and all of the advocates. Health equity means ensuring that communities in low and middle income countries receive the same access to high quality services and supplies as those in high income countries. It means that women who have been disproportionately affected by the pandemic are able to access health care and support they need. This is vital. Multiple populations have been affected: the LGBT community, immigrants, refugees, people living with disabilities. When we say health for all, we mean health for all. Always, but especially when it comes to pandemic preparedness and global health security. So as we begin our panel, this discussion on Universal Health Coverage Day, UHC Day, are excellent opportunities to bring attention to health equity. But policymakers, advocates, global health practitioners, politicians, and other parties across sectors must continuously strive throughout our work to ensure that health for all becomes a reality. I hope that you'll listen, you'll engage in the chat box, and apply our panelists' insight to your ongoing work. As Alicia mentioned, please feel free to introduce yourself in that chat box. Ask questions throughout the speakers' presentations. And we ask that you keep your microphones muted, please. Closed captioning and live transcription, it's available for this event, and it is accessible. This is an exciting opportunity for dialogue. So this event is virtual, it's across the world. We want to hear from you and your perspective. So I'll start with our panelists. We'll be asking 3 questions. Our panelists have deep expertise. Jennifer Ho, she is a feminist and human rights activist. She has more than 20 years of experience working with and advocating for rights of vulnerable and marginalized populations and communities in Asia and Pacific. She's currently the Deputy Director of APCASO, a regional civil society network of community-based and non-governmental organizations on health, human rights, social justice in Asia and Pacific. Dr. Mohammed here is a medical doctor and an internationally recognized expert in field epidemiology, operational research, and public health systems. He assumed several positions throughout his career in research, advisory. He's a consultant on several assignments with the US CDC, the World Health Organization, and much more. Smita Sadasivan, she's a self-advocate for cross-disability rights in India. She's worked for the advancement of the human rights of persons with all disabilities at the national level for the past 16 years. She focused on advocating toward formulation of rights-based policies and programs for persons with disabilities by the government and implementing them, and has many roles. And Dumisu Gacha. Dumi is proudly Pan-African and an unequivocally non-binary queer feminist working on eliminating the barriers between grassroots experience and global policymaking. They are the founder of Success Capital Organization, which is a grassroots organization providing community health referral services and advocates for the sexual and reproductive health and rights of communities that are underserved. Dumi is the vice chair of Gender Dynamics, a standing international member, representative of Amnesty International, and a member of USAID's Global Youth Advisory Council and Africa Queer Youth initiatives. So thank you, panelists, for being here today and sharing your experience. We'll start off with the first question, and it will go Jennifer, Mohammed, Smita, and Dumiso. So Jennifer, how would you define health equity? It's a tough question in the context of global health security.
Thanks, Lisa, and thanks also to the organizer for the opportunity to be here today. So it is a tough question on how we define health equity, but it's also not a tough question, Lisa. So a little bit of a background. This year, our network, CASO, which, as you mentioned, it's a regional network of civil society and community-based organizations on health, human rights, and social justice in Asia Pacific, in collaboration with the Civil Society Engagement Mechanism for UHC 2030, we conducted a series of country-level community and civil society-led consultation on universal health coverage to be contributed to this year's global report on the state of UHC. And this was especially critical as civil society, governments, and donors grapple with the impact of COVID-19, as you eloquently expressed earlier. And one of the comments that gathered from the consultation, and I think really, really helped respond to your question, was a consultation in Nepal and a quote from one of the participants, which I think points to what health inequity is. And the quote was, "You either pay or you die." And so for me, health equity is about everyone having access to the health services that they needed, when they need it, and how they need it. And without fear or concern for personal safety, and without fear of facing catastrophic financial hardship. So that's kind of how I would define what is health equity through the lens of what the equity we're currently seeing right now. Thank you.
Thank you, Jennifer. Yeah, and you bring up important points about personal safety, financial security. So thank you for that. Dr. Mohammed, we're going to turn it to you next. What is health equity?
Very much, and it's my pleasure to be part of this this team. I will tell you what health inequity looks like, and then each of us can tell what health equity really means to them. Health inequity is when, for example, vulnerable communities and poor parts of the world cannot access healthcare in general or vaccines in specific. It's when human behavior lead to unfair and avoidable poor health status and unfair systems that will ultimately impact everyone negatively. So, if you may, you can perceive health inequity as the strengthening health security. Thank you.
Thank you, Mohammed, Dr. Mohammed. I think, bringing those correlation between equity and inequity is very important. Smita, or let's go to Dumi because I don't see Smita up yet. So let's go to Dumi. Dumi, you've worked a lot at the country level. And let's remind everyone to mute if you're not speaking. Thanks. So Dumi, how would you define health equity?
Thanks so much, Lisa. Thanks so much to the Global Health Council. So I think I shared a bit around this question in a preceding blog to the symposium. And so maybe I will contextualize by giving a practical example. So for instance, Lesego is a young queer gender non-conforming foreign national from an ethnic minority community in a peri-urban location that's overburdened by the COVID pandemic. Equity within this context looks like respect for their religion, whilst accessible, stigma-free, and meaningful care is provided in an emergency situation. This looks like being communicated to in a language that they can understand without influences of misinformation or disinformation, having intentional approaches to care that consider possible psychological needs and listening attentively to signs of possible compromises to body autonomy and integrity. This might look like having been forced into a marriage whilst under the legal but not cultural age of appropriate marriage consent, or even looking out for trauma trigger responses or navigation tools for survivors of gender-based violence. And I think it's really more holistic, it's intentional and integrated in diagnosis, treatment, care, and support beyond science and standard operating procedures. Thank you, Lisa.
No, it's absolutely beyond science, right? When we're talking about equity. And I think the policies that get people access is vital. And some of the things that you've mentioned. Smita, we're going over to you at this moment. A reminder to everyone to mute if you're not speaking. Smita, what is health equity to you?
What is health equity to you?
As we understand, health equity is about health services, effective quality health services being available to everyone, including all diverse population groups, and it does not marginalize specific groups like persons with disabilities or LGBTQ or other disadvantaged groups. And it should also be usable. Health equity can be considered a success only when it is assured to be usable to all people. And how can we ensure that? We have to identify the barriers faced by different population groups, and these barriers need to be addressed, it need to be removed, and reasonable accommodation need to be provided to different marginalized populations like persons with disabilities, so that health equity is successful. Otherwise, we cannot call it a health equity because accessibility, availability, and affordability are key to all population groups, and it cannot leave out certain population groups. And CSEM, Civil Society Engagement Mechanism for UHC 2030, have come up with a Health for All toolkit for advocating on health equity for civil society groups. They can actually use it for their advocacy in country level. Thank you very much.
And Smita, your work with people with disabilities, we say that people with disabilities are the missing billion in the world. So, we're talking about that access, that accommodation. It's so important. I'm going to shift right now and go to the second question. So when we're thinking about global health security, how does health equity relate to global health security? And Jennifer, we're going to start with you again. So what does that mean between health equity relating to global health security in your experience?
Thanks, Lisa. And it's tough being the first panelist, isn't it? But to answer to your question, I'd really like to start out by challenging the notion of whose health are we talking about and whose security do we mean when we use the term global health security. And I think the COVID-19 pandemic has really demonstrated to us that, when the world talks about global health security, especially the Western world, what they really mean is the health of their own populations and the security of their own national borders, and most importantly, of their economic structure. You can see that through the hoarding of the global supplies of the COVID vaccine and medicine. It's not only selfish and unethical, and it has also led to massive health security risks for the rest of the world. And I think the various speaker earlier and you yourself have also alluded to that. I'm from the HIV movement, and in the early days of the HIV pandemic, the world, especially the governments in the West, did not care much about HIV and AIDS, and it ran rampantly first through the gay communities, then communities of people who use drugs, transgender people, and sex workers, and so on. And what did those communities have in common? They were the most marginalized and the most vulnerable members of our society, and they didn't have access to the health services and the care that they needed. and their needs weren't even acknowledged, nor were they considered relevant to the global health security framework. While activism played a huge part in us finally able to get government's attention, to finally get government put money into supporting services needed by these communities in our response to the HIV pandemic. However, what's really hard to swallow, and it's a hard truth sometimes, it's that what really got governments eventually to cough up money for our HIV responses and attempts to address some of the structural inequality with sort of policy reform was because they saw the potential impact of not addressing this disease on their economic structure, on their ways of life, and on their security as the world power. So I think the world learned a really hard lesson back then, but it does not seem to have fully grasped that when we talk about health equity, especially as we live through the COVID pandemic. We are back to where we were before. And so I think what we should be talking about and how do we reach the most vulnerable, the most marginalized, the most left behind population, that gap within our society, not just not just for their health needs, but also their social and economical needs, that health equity. It's as Dumi was saying earlier, it's not about science, it's not simply an issue of health, but really it's the overall human development needs that all of us need in order to move forward toward a more fair, more just, and more equitable society. Thank you.
Jennifer, I'm so happy you brought up the HIV/AIDS epidemic and really looking at some of those similarities between cross-border restrictions that we're seeing with travel bans with COVID-19 and what we saw with people living with HIV and AIDS and the travel restrictions and immigration restrictions they face. We lost so many people, our friends, our colleagues, our patients. And we just celebrated World AIDS Day, but you're right, we haven't learned much. There hasn't been those changes. Civil society groups. Dumi, Mohammed, Dr. Mohammed, are you there? You popped off for a second. So while we're waiting to see if Dr. Mohammed's there, Dumi, I'm going to go to you. And when we're talking about equity and global health security, how do those two relate?
Thanks so much, Lisa. I think, they work in tandem, although the latter can often exclude many groups as a result of inherently supremacist, ableist, and elite systems. I think I need to clarify that it's not about individuals and practitioners, but it's really about systems that dictate standards, norms, and evidence that always excluded, groups such as people of color and other demographics that were not always considered normative or that are often preceded by inequities. And I think, equity in the context of health security requires resources, the kind that enable meaningful and equitable participation that includes reparative and just deployment of intellectual property, along with the means of production for equity in medicines, logistics, and financing architecture, democratic freedoms for informed health-seeking behavior, community health systems that are supported by social protections, and social participation in the design, implementation, and reviews of health interventions amidst pandemic preparedness, responses, and recovery measures at all levels, local, national, regional, and global. I think this can always be strengthened by legislative instruments that expedite and mobilize infrastructure, but also personnel and multi-stakeholder collaboration, which should already exist across, private, public, and civil society sectors. Thank you, Lisa.
No, thank you, Dumi. You've mentioned personnel and legislation and really mobilizing these. I think we've learned about health system failures and gaps in the health systems during this pandemic. And I really like how you're framing this in terms of social protection and some of the lack of social protection we see. Sometimes we're focusing too much on vaccines during this this pandemic, or counting doses instead of all of the barriers and challenges to get it into somebody's arm, right? We shouldn't be counting these vaccines as doses that arrive in a country or donated. We have to see how many are actually making it right here, and how many people have protection that they have access to this. So, excellent points. I really appreciate this. Dr. Mohammed popped off again. He's going to come back, I'm sure. Smita, we're over to you now. And so this theme of health equity relating to global health security, what are your thoughts on this?
Basically, health security is based on health, and health should not be assumed to be freedom from disease, but it should be perceived as a whole well-being, physical, mental, and intellectual, and social well-being, according to the WHO definition itself. And basing health security on health. So it is a comprehensive and a collective state of promotive, preventive, and treatment, curative, or palliative and rehabilitative care. And while talking about these different aspects to be part of health security, health equity plays a major role, because when people from different marginalized groups are left out, we cannot talk about health security, like Githinji mentioned in his keynote address. So when we are looking at health security, again, we should identify the barriers. We have to address the barriers faced by people of different disadvantaged groups, and only then we can achieve health security.
Thank you, Smita. And you bring up, if you can mute yourself, thanks. And if you think about health, as you mentioned, is not only the prevention, the treatment, but also the rehabilitation part. We've seen during this pandemic, in the context of global health security and this long COVID symptoms, that there are whole groups of people that have experienced these long COVID symptoms that are really affecting their lives day to day. So in future global health security events, in the planning and where we are right now, we can't forget that rehabilitative aspect, because it does tie into disability, and then we have another marginalized population from an underserved population from COVID-19. I see Dr. Mohammed might be having a couple issues. If we get him back again, I'm going to grab him and get him to answer this question. But while that's happening, I'd like to move to the next question, if that's okay with everyone. And for our last questions, and I really want to encourage the audience, all of you out there in the virtual land across the world, to add your questions and your comments in the chat box. I see some of them have been there in terms of, thank you, Eliana, for putting the toolkit link, which is now in the chat box. That will really help in terms of UHC connections. And then some really good comment about mobilizing communities to achieve UHC in rural areas through community-led action and partnership. So thanks, John Kunrad, for that. We see a couple questions from Rawan Araj. We'll get to those later, but we'll, in the meantime, go to this third question. So can you give us some specific examples, Jennifer, of how we can integrate health equity into global health security? And eventually, how can we achieve this greater health equity?
Thanks, Lisa. Let me start out this by sharing again another quote from our UHC consultation. And this one comes from Japan, which for those of you who are familiar with the UHC agenda, we all know Japan has been put it on pedestal as, you know, an example for how UHC should be achieved. And the government has been the champion for UHC agenda globally. But gaps still exist. And, you know, one of the quotes from the participant in our consultation was that the greater the vulnerability of an individual, the greater the time, cost, labor, and patience required for that person to expand to access health and medical care. And this is Japan, right? Where we believe that a health system, it's so perfect to a certain extent, and it's available. And before I give an example, I think, you know, what do we need to achieve greater health equity? I think we need programs, we need policies, and most importantly, we need investments that are people-centered, community-focused, that are grounded in principles of human rights, programs and policies that are gender transformative. We need to invest in strengthening in community system, investing in communities and people because of the community of people, because they know best how to reach those who are currently being left behind, and how these people need to be reached and the kind of services they need. People with addiction problems should not be treated as criminal. Rather, they should have access to addiction treatments and services. Transgender people should have access to the health services and care, such as hormone treatment that they needed to live a dignified life, and policies and laws that criminalize people based on their sexual orientation should be repealed. You know, sex workers' rights are human rights, and it means that people having access to mental health services that they need it and when they need it. One of the ways that, you know, countries in my region have been trying to achieve greater health equity was through the National Health Insurance Program as part of the UHC agenda. And, you know, and for example, in Vietnam, they have implemented tier payment system based on your income ability. And most successfully in recent year for us working in HIV movement was that this is one of the few health insurance program very early on integrated coverage for people living with HIV so that they could access their medicines without fear of, you know, financial consequences. But I also want to point out that National Health Insurance Program is and should not be our only answer to addressing health inequity, right? We need a comprehensive social protection program that addresses all the other structural barriers people face in accessing health. And for us to address health equity, again, it's an issue bigger than health. It's bigger than the health system that we need to be looking at. It's all the ministries that we should be having conversation with about how do we come up, for example, the monies and put the right policies, and how do we better engage community members in monitoring how are we doing in our progress to achieving equity in health. Thank you so much.
Thank you so much, Jennifer. And I think one of the most important points that we're hearing is this equity issue of inequity in a global health security lens is beyond one event or another. It is not just for this pandemic. It has to be built into the national health system. There has to be continuous investment. And really looking at people, I love how you said people-centered investment. We know with this particular event and other crises, we have a lot of investment from multiple donors, from banks to the Ministry of Health. Maybe the Ministry of Finance isn't talking to the Ministry of Health. There should be national health programs and insurance programs and social protection programs that are consistent across one crisis to the other. So, you know, I think linking to UHC, this global health security, program and equity program is so important. I still don't see Dr. Mohammed. He popped up. So Dumi, we're going to go to you. With live events, this is always interesting, but thank you everybody for your flexibility. So Dumi, let's talk about some of these specific examples and how we integrate that health equity and how can we achieve the greater health equity?
Thanks, Lisa. I think, more specifically, now speaking to budgeting, gender at-risk group or even vulnerability-specific budgeting is one sort of key example. And I think, that really does allow for including and accommodating diverse groups, inclusive of internally displaced individuals, undocumented migrants, particularly through intersectional approaches and not just check boxes that need to be ticked or linear programming. I think this includes structural interventions that are aimed at addressing inequities that are deeply embedded in institutional racism, colonial gender disparities that pre-existed. I mean, we're speaking about, 2021, and I think it was 2 weeks ago where the Court of Appeal had to dismiss the government, or not necessarily dismiss, but sort of safeguard the right for LGBT groups to have relationships in an era where ideally within the context of our NSF3, which is the National Strategic Framework of HIV and AIDS, really does acknowledge and strengthen the rights of LGBT groups. So I think it's also recognizing, gender beyond binaries in the context of programming. And, in as much as people speak about political will, but I think it's really rather not necessarily always registering to the, political whims of leadership and acknowledging that, administrations do change and that the geopolitics that exist need to be essentially targeted in some way, particularly in ensuring that community health systems can be able to withstand regardless of where the wind blows. And I think integrating this towards holistic service provision and actually targeting, ableist infrastructure. And I think more notably really around sanctions, travel bans, and multilateral cooperation that are anchored on nationalist, apartheid, or punitive measures that compromise solidarity and humanity. I think, this means disaggregated data in accordance to vulnerabilities and inequities, accountability in resource deployment, inclusion in decision-making structures, and enabling environments for partnerships, to scale efficiencies, eliminate waste, and harness lived experiences expertise. So essentially in sort of addressing value systems embedded in public health. And I think lastly, the civil society engagement mechanism for UHC 2030 has several comprehensive and practical tools, particularly in our e-library, tools ranging from, social participation handbooks, the Health for All toolkit, as mentioned by Smith, previous webinar recordings, presentation slides, thematic recommendations, whether on COVID-19 or HIV and other thematic issues, and online engagements to stimulate public discourse and even sort of try and influence some of the technical outputs that are created across the health governance spectrum, at least towards health equity. And so I think this is quite critical for us to recognize that there's so many multiple players within the context of sort of addressing inequities, but more importantly that we can integrate this at different levels of engagement. And I think as a last sort of appeal is really doing no harm in recognizing that there can be blind spots and being able to actually address systemic issues that impede us from being able to address these inequities, because for some reason they keep popping up regardless of what pandemic we're dealing with or when there's a crisis. Thank you.
Thank you so much, Dumi. Do no harm is a common phrase we hear with humanitarian crisis, but it should be all the time in a health for all agenda. You bring up some really good points about decolonization of global health, and that's not only in policy, but it's also in the legislation. And some of the things, if we're not counting people in data, if we don't have desegregated data, if we aren't holding people accountable and making sure that funds, investments are earmarked for populations such as the LGBT community or people with disability or women, that we will never have equity. So I see Dr. Mohammed's here. You brought up excellent points, and I want to go back to those. Dr. Mohammed, we're so happy to have you back. We would love to hear from you. How does health equity relate to global health security? And if you can give any specific examples of how we can integrate that.
Thank you very much. Can you hear me now?
We can. Thank you so
Yeah.
much.
Excellent. And sorry for my interruption. It seems we have a problem with the internet. So, in a brief, health equity and global health security go hand in hand. And maybe you have heard it a million times, but I will say it again. Disease does not know or does not know borders, and disease does not know discriminate. We have been warning for a long time now that the diseases like coronavirus will thrive as long as many parts of the world lack vaccines. And yes, Omicron, the latest variant, and perhaps others, may be one of the dire results we have to face because of COVID-19 vaccine inequity. It's not only coronavirus, but many diseases know no geographical borders and will require global cooperation and need to expand harmony and take collective response to really reach what is called global health security. It's worth to mention that 80% of all vaccine productions goes to 20 countries all over the world. However, if we take Africa continent as example, it was the vaccine availability less than 1%. So this is part of what we are witnessing nowadays, having more, new variants and circulation of the barriers due to the discrimination and due to the inequity, and as a result, the whole health security issue is in a very difficult situation. Thank you.
And Dr. Mohammed, while we have you here, how do you think that we can integrate those health equity into GHS, and eventually achieve health equity?
So one of the things, thank you very much for the question. We need to empower communities and partners locally and globally to act in support of demand and equity. And one of the example, we are at Eastern Mediterranean region network Infinite. We have started while ago a petition to advocate for the equity of vaccine distribution and ask higher income countries to allocate around 20% of the vaccine production to developing countries. Another, also, a leading public health network in the Eastern Mediterranean region, we as Infinite, we were active partner and member in COVID-19 immunization partner coordination group and the regional group working for COVAX, all in support for closing the gap in vaccine equity. So many ways, that we also contributed to COVID-19 national development and vaccination plan for countries and supporting the implementation of their national training plan to roll out vaccination, COVID-19 vaccination. I think collectively and jointly we can work with different partners in the region and the globe to improve the health equity and to secure or to reach global health security issue. Thank you.
Thank you, Dr. Mohammed. This theme of empowering communities is coming up a lot. And it's not just about COVID-19. It could be HIV or Ebola or any other NCD, mental health, disability. We need to empower communities to act on the global health security program. And that takes investment, as Dumi mentioned. We heard recently from Samantha Power at USAID that a lot of their investment will now be going directly to the country level, to communities. And I think that we need to empower communities through that investment. We need more donors. We need to actually translate that investment to the community and civil society to be part of the global health security agenda. We know that surveillance is so important, that bringing communities that do not have access is just vital to achieving the equity. Smita, you're here again. I'm so happy. We're looking for specific examples from you on how to integrate the health equity into global health security and achieve health equity. And you're on mute, so if you can unmute yourself.
Yes, I hope you are able to hear me. Thank you for that question. And yeah, again, with regard to some certain examples from the regional level of Asia Pacific, I would again come back to the addressing barriers, because why I'm again and again talking about barriers is different marginalized groups or disadvantaged populations are facing discrimination because of the barriers in the society and not because they are part of that particular culture or that particular group. So for persons with disabilities, we face a lot of barriers in the infrastructure, information, communication, legal policy level, or even administrative barriers. So back in my country, what we disability groups did is we advocated with the government, and in my state, we advocated with the state disability commissioner to come up with a helpline which is inclusive of sign language interpretation, so that people with hearing impairment or different deaf groups can be part of the vaccination information. Otherwise, no information was reaching them. And we also advocated with the government to come up with door-to-door doorstep vaccination for all persons with disabilities, because people with disabilities are already facing barriers in the environment and they are not able to come out, and the pandemic have created even more barriers. So the lockdown or whatever. And so we emphasize the government that doorstep vaccination should be provided to persons with disabilities, and successfully it was done. It is being done. And if you look at the Asia Pacific region also, different civil society groups have been working towards health equity. It is the civil society groups who are actually producing the result on health equity by even for this pandemic. They have been distributing medicines at the doorstep of persons with disabilities, and also distributing paramedical supports or providing online support for counseling or telemedicine or socialization, etc. And those people who required regular infusions, they were provided that facilitation in their own community. This was also done by the civil society groups. So, civil society groups are an integral part of health equity, and they need that recognition from the governments. This I would like to stress upon. Thank you very much.
Okay, thank you, Smita. There was a little bit of Wi-Fi issue, I think. But, I think these are incredible specific examples where you're working closely with government, giving very specific recommendations, and then it takes for them to implement it. So the use of sign language, going door to door. These are really, really excellent equity examples. We're going to go to some comments from the audience right now. And so I urge you all to put your comments in the chat box. I'm going to start now. I see one from Paul Miller. So Paul noted yesterday, and they're popping up on the screen. This is great. Paul noted yesterday the costly and relatively inefficient health investments for high-end treatment in stratified countries like the US. What criteria should we use to judge the relative equity of health investment by government, private sector, and donor? So who would like to take that question? So we're looking at sort of this inefficient health investment. So it goes back to some of the things Dumi was talking about, Jennifer. Would anyone like to take that? What criteria should we start using to judge this inequity of the investment? Smita?
Thank you, Lisa. So the government should look at involving people advantage of by the government itself is what I think. And apart from that, the government should also ensure that information is provided in accessible formats for everyone, for people. Otherwise, the governments may come up with different programs, but it will not reach people. So,
I'm not sure if it's my Wi-Fi. Are others hearing Smita, or is it faded out? I did catch the importance of having governments really have different materials available when they're talking about investment. Would anyone else like to address this question in terms of what criteria do you think that we should use to judge these in the relative inequity of the health investments? Dumi, you want to go ahead? Thanks.
Okay. Thank you. Sorry, Jennifer. I think maybe just quickly also just to sort of address, something that you had mentioned a little earlier, Lisa. I think the first is diversity in resource pooling and sustainability. I think this is really quite key in ensuring that, there is obviously meaningful participation and that there can be accountability from different stakeholders, regardless of the sector that they come from. But also just to further push, aside from the need for more donors, I think we need to curb illicit financial flows, recognizing the role that multinational play in denying the state enough resources to ensure service delivery. I think similarly, we need reparative justice, particularly in the context of the extraction and exploitation of groups and my continent, which has perpetuated underdevelopment and exorbitant debt trends that deny meaningful infrastructure development. Similarly, taxing the wealthy appropriately will address the needs, for universal income floors and enable UHC. I think we need to push away from, capitalist framing, particularly around value systems and language, as it negates from acknowledging, the essential components of care work, rest, and prevention as key components, not just for wealth, but also for well-being. And I think, this will also sort of enable more discourse around socioeconomic rights. So not just, the more prominent human rights-based approach to public health, but really towards progressive realization and accountability through litigation and reporting to ensure equitable health provisions and uptake, particularly in the decade of action.
Excellent, Dumi. This reparative justice concept, when we have countries that really have horrible policies against and discrimination against certain groups, and how will the funds flow to these countries that are actually persecuting groups during pandemics and beyond? So, Jennifer, do you want to give a stab at this question in terms of what are criteria? It's hard to follow all of that, Dumi. Amazing.
It's absolutely difficult to follow Dumi. So, but I'll take a stab. And I'm not an economist, but what I do know is that there's been a number, and we consistently do this. We do investment cases of how much do we need to address a specific health conditions and crisis. And we do this over and over, and then we present the figures. But one thing I do know, and I cannot quote the figures for you, but what I do know is we consistently fall short of what's needed for us to address all the health issues that we need to be addressing, that the minimum standard that we can't even meet collectively, whether that's on the part of government, on the part of donors, or the private sector. So that's my response. I don't know what the criteria should be, but what I do know is we're nowhere near what we need for addressing what we need at the moment. Thank you.
Yeah, no, thanks, Jennifer. And I think this issue of accountability is so important. We have social accountability, we have performance accountability, we have financial accountability, and using those beyond toolkits, beyond checklists, getting accountability at the government level through the funding mechanisms, whether it be funding for COVID-19 and vaccines or donations of vaccines. There has to be that accountability there. So, I really appreciate all of your answers. Dr. Mohammed, I'm so happy that we're here with you. And, I'd love to hear a little bit more on what you're thinking about these high-end countries and some of the investments. What criteria should we start using? These are rich answers.
Very much. I think one of the things that World Health Organization and different countries all over the world trying to use or to establish is universal health coverage. And using universal health coverage, we can identify the essential healthcare packages that we need, just to make it as a baseline for different countries according to the health status, economic status as other. I think as much as we can go with the universal health coverage, we can reach clear, defined criteria for such equity. So universal health coverage could be one of the tools that could secure, or at least to help us to reach the health equity. One of other strategies that we need to work on, and we see, after COVID-19 pandemic that we are suffering with, the concept of public-private partnership is not clear still, not very well defined in all countries over the world. So some of the countries they could apply such a concepts, and it became very clear how the multi-sectorial and multi organizations can work together to reach such criteria. However, in different other countries we could not. The third component that I like, to share also the importance of the empowerment of the national and local local entities, so we need more to work on empowerment and, to make sure that we are listening to different voices from the countries, from the region, from the different players in the country. So this is in general, that I think these type of things that we need to think about it. Thank you.
No, thank you, Dr. Mohammed. We've heard words like empowerment, mobilization, advocate. I think one of the strongest here was reparative justice. Yes, do me. In this discussion. And we're having this discussion on equity and global health security on UHC Day. So I want to ask you all a question regarding UHC equity and global health security. And if you could make one recommendation to all of those crafting UHC plans, whether at the national or global level, and also investing in UHC in the discussions that we're having today. What would that be? What would that recommendation be that we need to incorporate into UHC plans more? And so, Smita, would you like to take a stab at this question? You've had some great examples already. So over to you.
Lisa, so inclusion is key, and inclusion should not be namesake, it should be effective. So include people from different populations and marginalized groups, and providing reasonable accommodation to them so that they can participate effectively and in a dignified way on an equal basis with others. If this can happen, then we can get into health equity, and also the universal health coverage as such at every country level can be planned with all including all marginalized populations. And so inclusion is key, and accessibility should be understood by the perspective of people itself, and not just from from a holistic from just what to say a stereotypical outlook. So what does accessibility mean to different groups of people? That needs to be addressed. It can be financial inaccessibility, or it may be informational inaccessibility, it may be infrastructural inaccessibility, or communication inaccessibility. So people living in remote places have issues to reach the district headquarters for their health coverage, and many people are dying, and with the pandemic it is more so. So how do we provide health equity? So all these contexts should be thought about, and when these barriers are addressed, then we can achieve universal health coverage. Thank you.
Thank you very much, Smita. And what this, what inclusion means, if you can mute Smita, please. Thank you. So when we're looking at inclusion and accommodation to incorporate more into UHC plans, there's two schools of thought here. Often we silo underserved groups, people with disabilities. We label them, we put them in a side. They aren't incorporated across and integrated into the health plans. People talk about nutrition interventions and then nutrition interventions for people with disabilities. I think that there has to be a greater inclusion across technical areas, across financial earmarking, for whether it be people with disabilities or LGBTQ or gender, women's groups, pastoralists, refugees. So, I really appreciate your comments. Dumi, I'm going to go to you next. What is the one recommendation that you would make for UHC?
Thanks, Lisa. I think, for me, it's feminist leadership, especially around intersectionality. I think this requires moving away from co-opting and, to some extent, even weaponizing the bodies and experiences of those who are most impacted or affected. I think we need to really differentiate between integration and mainstreaming. We need to recognize that hierarchies and structures are inherently filled with power dynamics, and we need to continuously question who's not in the room when we decide or deploy. And I think lastly, I love thinking about solidarity as sunshine, and everyone deserves some sunshine. So we really should be questioning, which plants have been denied sunlight, which haven't been pruned yet, and also, which, deserve, some weeding to ensure that, everyone can be able to experience a little bit of sunshine within the context of health equity. Thank you.
I love that analogy, Dumi. Love it. And, the concept of sunshine or even rain. We know the UHC umbrella's there to capture the rain. So thank you for that. I'm looking at the time. I want to get to some other questions. So Jennifer, what would be your recommendation for UHC in terms of equity and global health security?
Thanks, Lisa, and I'll keep it short. I think for me, it's really to invest in community system and community capacity. UHC is and should be about the people, and without investment in the community and in the community system, there's no way we could reach a strong health system for all at the end of the day. Thank you.
Thank you, Jennifer. And Mohammed, what's your recommendation, Dr. Mohammed?
I agree with colleagues. We have to think about partnership, more coordination, and bringing all people to the room, to the table, to talk, to exchange data, exchange knowledge, and to build all these solidarity among country, within the country, within the region, within the globe. So we are part of the globe, that, and we have to contribute in global health security. And I think what we are seeing during this experience, about data exchange, knowledge and information is a good sign that we need to emphasize on, and to bring such approach, broader in the future, and how we can learn from each other, and how we can, together to reach, the best of what we can from global health security and universal health coverage at the same time.
Thank you, Dr. Mohammed. And, the Global Health Landscape Symposium is a perfect example of that, of how they're bringing together, Global Health Councils bringing together people around these topics. And Dumi mentioned before, many of the other types of regional or national forums that exist. Many of you are part of networks that are doing this knowledge exchange and information. But I think one of the points that Smita brought up about access to information and the access to these opportunities is so vital. We know a lot. I think the statistic was 95% of adolescents and youth are using phones for access. And we have, in previous events like this, 50% of people were using mobile phones. And so do people have access to phones? Do they have access to data? Do they have access to electricity to see these things? These are important concepts that are all tied into this information and knowledge exchange. So I want to move to something extremely important regarding gender, equity, and global health security. We know that 80% of the health workforce is women. We know that many of them are not paid. We know that women were disproportionately affected. And we know that gender is not binary. And that we need to unpack this a little bit more around the equity and global health security. So I really would love to hear from all of you, what is your opinion? And can you give some examples of things that have worked in the discussion of gender, equity, and global health security? So we will go to Dumi first, because they are right next to me on the screen. And I'll give you a second to breathe and think about that. We had a gender forum. Was it equitable? I think people were invited to the Generation Equality Forum, and then they had to leave the next day, or they were waiting outside. How do we have access to gender equity when we're talking about global health security? So, Dumi.
Thank you, Lisa. That put me on the spot a bit, but nonetheless, it's an exciting question. I think, firstly, for me, the immediate thought was really care work, particularly around recognizing that there's a high level of, or rather a high need for care work at individual, institutional, and at community levels, and that this often isn't factored in within the context of an annual plan, or even within the context of an M&E framework, and that there's a need to sort of recognize that. And more importantly, that there's a need to sort of embed that within the context of the economic implications of time and productivity. And in as much as that might be capitalist, unfortunately, that's a way of engaging, and that's really an integral component to social systems, which is the very basis of why disparities exist already anyways. And so I think within the context of gender diversity, it's also recognizing that there are limitations within the current context of language, right? Within the current context of identity, and how self-determination has such a significant impact. But I think it's almost impossible to separate issues of gender than other identity issues, whether being a migrant or being a young person and so forth. And so I think it's really quite critical, as mentioned, really about feminist leadership. And I think gender being an afterthought to preparedness and investments really shouldn't be the case. Many activists, at least on the ground, and community health systems were calling out gender and intimate partner violence, as the pandemic had started and as, lockdowns were occurring. And it only took, I think a month or 2 months, for, one of the UN agencies to say there's a second or shadow pandemic of GBV. And so I think it's very important for us to recognize, listening to the grassroots activists, listening to those who are impacted and most affected are really the experts in the context of, equity. They are really the experts. And we see that happening now within the context of the HIV response, at least through different forms of social participation. So I think it's very critical for us to just recognize, how deeply important feminist leadership really is. Thank you.
No, thank you very much. We're talking about the COVID-19 pandemic and everyone's talking about doses, shots in arms, but you just brought out some really great points about the gender-based violence that occurred. And when we talk about gender transformative approaches to programming, to response, to UHC, how are we building in those indicators? How are we building in the voices of the people affected? How are we building and using language that reflects what the current situation of identity is, whether it be regarding gender or refugees or internally displaced people or other groups, people with disabilities. So thank you for those reflections. Jennifer, you're next on my screen. So I'm going to turn it over to you for a couple of reflections on this really important topic.
Thanks, Lisa, and thanks, Dumi, for always really, really passionate and so articulate in your responses. But well, coming from Asia Pacific, I think, when I think about gender, in addition to all the things that Dumi raised, I think about the socioeconomic status of the woman and how that really, 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 really does impact whether or not they have agency, whether or not that they could be empowered to really have a say in determining their own well-being, in the positions that they have in the household, and whether or not they have access to information, or how they could access healthcare, whether or not that their health is prioritized in a household. We work with communities that are impacted by malarias and TBs here in the region as well. And oftentimes these are, cross-border migrants. These are urban poor communities that we work with. And often what we see is when resource comes down, and again, money does matter. And this is where oftentimes women get deprioritized, they get left out. It's men's health that are the most important. That if there are only so much money in the household, and given that you help access, it's either you pay or you die, and you need to pick somebody within your household to make sure they're healthy enough to continue to bring in income. It's always the men's health that get prioritized. So I think that, again, it comes back to addressing the social inequality issue, the socioeconomical, the various barriers that we see in access into education, as well as accessing to employment opportunities for women as well, and to really change the gender perception of, women's role within a society, within the household. And I think at the end of it, it really comes down to the basic of, bringing everybody together and making sure that everybody have the opportunity that they need as a human being to actualize that to their fullest potential. Thank you.
Thank you, Jennifer. And bringing it back to some of those financial implications of health and how gender works into that, I think is really vital. When talking about UHC, when talking about global health security, these types of issues have to be in the planning as well as the investment and the legislation. Thanks so much for that. Smita, over to you. How does gender fit into this conversation on equity and global health security? Thank you. You have to unmute. Thanks.
You have to unmute. Thanks.
Thank you, Lisa. So I agree with Dumi and Jennifer. Yes, women with disabilities are last in the queue, but they are the integral part of any community or even the health system. For example, Dumi was mentioning about the gender-based violence. Even we saw during the pandemic time, women with disabilities faced a lot of domestic violence and sexual abuse because they were completely voiceless and they were kind of dependent. They were made dependent on the households, and when other members of the family or the community were there around, and they tend to um, uh, force violence on women with disabilities, which we actually experienced. And the other thing is about gender responsive healthcare should be inbuilt in the community within the healthcare system. And right now many women are given opportunities in the health system as part of the community, but is it real inclusion, or is it namesake integration? Yes, women have a need to earn and they are available, whereas there is the system which has a need, and so it wants to match its need with the women folk who are easily available, and so the system is actually taking more advantage of the women folk without providing adequate pay, without providing the equal dignity, or without providing enough training for that matter. So they are in the community, and at times they also are helpless while helping the people. So when we talk about inclusion, whether it is about gender or with regard to any disadvantaged groups, it should be effective inclusion with dignity. So that is key, is what I think. Thank you.
Thank you. Thank you so much, Smita. And I'm thinking beyond the sunshine of access, the umbrella of protection, we also need to have a megaphone that raises the voice of these women, of multiple underserved groups. Dr. Mohammed, I'm going to give you about a minute or so because we're going to wrap up. So tell me what your thoughts are. How do we incorporate gender discussions into equity and global health security?
I think I am coming from the region, Eastern Mediterranean region, which always gender issue was a big concern. But due to the current emergency situation in the region, since 2/3 of our country under emergency, and we have many insecurity, health, hard to reach areas, all these things, I think it was obvious to all that the importance of gender role in supporting the health system in these countries. And we have a beautiful examples about the role of females in supporting healthcare services. And we have beautiful examples, successful examples about female health workers. I think we need to integrate gender in all our strategies and plan. And nowadays, after decades, we see the difference of how we could women in generally, or females, they did a great and respectful progress toward being part of the health systems and in general in the society. So hopefully we gradually and together with the international support that we can also improve and position and empower the role of females in our health system and in our communities and in societies in general. Thank you very much.
Thank you, Dr. Mohammed. It's been my pleasure to meet with you today. I wish I can meet you in person because you are four fabulous individuals that are really making a difference in your communities and globally. And I'm hoping that all the participants from around the world take some of these examples and reflections, and they process that in their work. They advocate for that with the local government and national governments. That donors hearing this put the investment in communities, in underserved groups, that the language that we use is decolonized and we think about gender when we're speaking. And I just want to thank Global Health Council for bringing such important topics to the Global Landscape Symposium of 2021. You have been fabulous today. I'd like to thank you all. And for all of our panelists, I'd like to remind you we have a 15-minute bio break where you can stretch, you can breathe, you can do a little health walking, take some glass of water, and then get back to the Global Health Symposium with the concurrent sessions. So many thanks to you. I wish you well. I wish you peace and dignity in your lives and in your work. And thank you very much. Happy UHC Day and happy end of the year.